You're listening to the Assembly on Pulmonary Circulation podcast, brought to you by the American Thoracic Society.
Welcome to another episode of Practical pH. I'm Kathryn Valle, a pH specialist at Mayo Clinic in Rochester. We're continuing our Foundations of pH series today. And during our last episode, we discussed the diagnostic approach to pH. Today, we're thrilled to be joined by Dr. Raymond Benza, who is currently the Chief of Cardiology at Eastern Virginia Medical School and Academic Chair of Cardiology with Sentara Health. He is an internationally recognized leader in the field of heart failure and pulmonary hypertension, with particular expertise in risk stratification. Thank you so much for joining us on the podcast, Dr. Benza. We'd like to start by asking you how you became interested in pulmonary vascular disease and what excites you most about the field.
Well, thank you so much, Kathryn. It is really my pleasure to be here for this podcast. I really enjoy these type of vignettes, as I think they're really educational, and to be able to listen to these type of things anywhere you are really facilitates the learning process. So I really like these things. Pulmonary hypertension, interestingly, wasn't my first love. I actually entered the field through the venue of transplantation, and back in the 1990s, when I was doing heart and lung transplantation primarily, is when I first got to meet patients with pulmonary hypertension, as there are no available therapies at that point, including ibuprofen. All the patients required heart and lung transplantation. And I was really enamored by these patients, one, because they were so young at that time and so full of life, and yet required a lung transplantation that would only give them an additional 7 years of life. And I went, wow, this is just not right. And I think that's what really sparked my interest in pursuing pulmonary hypertension as a field, because I knew it would be not only academically interesting, but incredibly worthwhile from a humanitarian position, because there was nothing to treat these young women. And so I became very interested in the pathophysiology, and then subsequently, developed research paradigms in understanding the genetics behind pulmonary hypertension, and then later the variables that we collected that seemed to predict risk. Because it's a philosophy of mine, until we really find the cure for pulmonary hypertension, they're really the way to make these patients live longer with the new drugs that we have, is to make sure we know how to use them adequately. And that's where risk stratification all comes to bear in its importance, as it allows us to use the armamentarium that we have now more intelligently and guide it according to a patient's risk for dying or having morbid events from this disease.
Thank you so much for sharing that with us. I think in terms of your motivation to go into the field, that's something that seems to be pretty universal amongst pH enthusiasts I've visited with anyway, that we all kind of started with a real interest in helping these patients. It's a pretty consistent theme. And so obviously it's very exciting when that's your kind of guiding star. I think that drives a lot of incredible work.
I
You
agree.
you hinted about already about the importance of risk stratification and why it's so important. Um, Kind of diving right into that, anything else you'd want to add about why it's important that you didn't mention already? And then kind of second part would be, what are some key diagnostic tools that you recommend we use to help risk stratify our patients?
Well, I think, risk stratification is important for, a variety of reasons. Uh, we we can't always apply a shotgun approach in the way we treat people in terms of therapeutics. And risk stratification really outlines a very regimented but practical way of treating patients based on the data, based on the literature, that allows the medicines to be used in appropriate scenarios. And I think that's really important. And risk stratification is also very important for the patient themselves. They really want to know how long they're going to live with this disease and what the disease bearings is going to have on their lives so they can prepare and plan. And that's really important. We often forget that, but I really would like to stress that it's really important to the patients to know where they are in their disease evolution, and risk stratification really helps them to understand that. Um, it allows us to use the most aggressive approach for those who are at the highest risk, and also maybe less of an aggressive approach in those who are extremely low risk, perhaps even still using monotherapy to avoid the plethora of side effects that our medications on in people who really don't need an aggressive therapy. So I think it's really important to consistently risk stratify, not only at baseline, although I think that's one of the most important things, because it really helps you set the trajectory of a patient's disease prognosis, but also serially as you're taking care of them. Any opportunity you really have or touch point with a patient is an opportunity to risk stratify, to recorrect their trajectory if they're not moving correctly with implementations in drug therapy.
Absolutely. I think keeping the patient at the center of it is invaluable. Any recommendations for our listeners about what kind of tools we would use typically to risk stratify for our PH patients?
Yeah, I think that the basic parameters that comprise our contemporary risk score algorithms, I think are very important to capture. I think at the beginning of a patient's trajectory at their first visit with us, when we're really deciding what their baseline risk is and to determine initial therapy, it's important to be as comprehensive as possible. And this includes not only a good history and physical and getting important demographic information about the type of pulmonary hypertension they have, their age and their gender, but also, key pieces of their physical exam, like their vital signs, and in their laboratory evaluations, how well their liver and renal kidneys are being perfused, their natriuretic peptide levels, which give us a really good indirect measure of how much duress the right ventricle is under. Because remember, the key thing for prognosis and really all these variables that we collect are really telling us what the right ventricle is doing. It's interesting that a lot of the parameters that have prognostic have very little to do with the extent of their pulmonary hypertension, perhaps with the exception of the pulmonary vascular resistance. But most of the variables really reflect how the right ventricle is doing in the face of this very high afterload. So functional parameters are important, like the NYHA class, the 6-minute walk distance, the shuttle walk test in Europe. Imaging is ultimately very important, including not only looking for signs of pericardial effusions, which really indicate high duress and high right atrial pressures, but also parameters of right ventricular size and function, and how badly it's affected the filling parameters of left ventricle. Hemodynamics are ultimately important at baseline because they tell us again the extent of the disease and also its hemodynamic effect on the right heart. Even lung function studies like the DLCO, which really capture that capillary alveolar interface, is very important because it tells us how much capillary dropout there's been with the disease, with lower DLCOs being associated with much higher disease risk. So all of these are ultimately very important because they help us encapsulate this into these validated tools, which we'll be discussing, I think, next, which are really the cornerstone for risk assessment. But I should note that these algorithms that we're discussing is really just one tool in the tool belt. It's probably your biggest tool. It's your hammer. But you need your screwdriver and your wrenches, which are, imaging and genomics and proteomics, which add to that risk stratification that you get from those baseline algorithms. So you have to use those together in addition to your clinical gestalt to really guide a patient along this pathway.
I really like that analogy. I think next time I'm in PH clinic, I'm gonna mentally envision myself with a big tool belt on. So Thank you so much, Dr. Benza. As you mentioned, kind of the next step in discussing risk stratification, as you alluded to, is the validated tools that we use. So would you mind touching on some of those specifically and how they can be used to guide treatment decisions?
Yeah, so we have probably 5 to 6 risk algorithms that we currently use now in clinical practice, and 2 of these were derived in the United States, and these were Reveal 2.0 and Reveal Lite. These parameters encase 12 different variables that are gleaned from patients' demographics, their vital signs, their laboratory studies, echocardiography, hemodynamics, and functional parameters. And it distills this into a score, continuous score from 0 all the way up to 15. And each one of these scores is associated with its own risk of survival. And so that using Reveal, especially the parent algorithm, which is Reveal 2.0, gives you an extremely fine level of discrimination. And as I mentioned, this is particularly important at baseline because that's where you're really setting the trajectory of risk for these patients. But it's also the most convenient to use these comprehensive scoring systems like Reveal 2.0 or the initial compare algorithm, or even the Swedish algorithm that have all these variables as part of that initial assessment, because you have it all at baseline. This is how you diagnose and make sure you're treating a PAH patient instead of a group 2 or group 3 patient. So if you have all the tools, use them. And so the baseline is when I really see that tools like Reveal 2.0, Compare 1.0, and the Swedish registry algorithm is probably going to be most useful. Now, in subsequent follow-ups, obviously you want to use a more abbreviated tool to predict risk that doesn't lose too much discrimination because you're not using all the variables that you would at baseline, but using variables that you're going to get every clinic. So tools that have, you always collect vital signs, functional status, a 6-minute, labs, and perhaps even imaging. And so these parameters minus I would say the more cumbersome tests to get, like catheterization or pulmonary function studies, allow us to use a tool that captures a bulk of the discrimination, not as refined as the baseline testing, but enough to make sure that our trajectory is correct so that we can course correct with different medications if we want to use them. And so the tools that follow up that are generally recommended are Reveal Lite 2, which takes really just the non-invasive parameters of Reveal 2.0 into a more abbreviated calculator, but still using a continuous scoring system to give you that very fine segregation of risk. Or you can use the ERS, ECS 4-strata system, which contains really just 3 variables and that allows you to do a quick and dirty assessment of risk. With that, probably not as fine of a discrimination as you get with Reveal, but if those are the only variables that you have, you could still capture a bulk of the risk stratification using that simpler system.
Thank you. I think the point about using data that we typically collect is so valuable. One thing I really appreciate about the pH risk scores that we generally use is that they are so pragmatic and easy to use and easy to have the data for, because I think that just makes them so much more easily able to be widely adopted and so useful.
Yeah, the important analog to that, Kathryn, is use all the information that you get. I mean,
Absolutely.
it's a freebie to get vital signs. It's a freebie to take a history to know if a patient's been hospitalized in the last 6 months, which is an important components of Reveal. You're already getting the labs. All of us get 6-minute walk tests. We all assess functional class every visit. And we get natriuretic peptides. So why not use all that information when we have it to give you a really good discriminatory score to help guide our patients?
Definitely. I wonder if you would just comment on something that comes up clinically quite a bit. For these risk scores, are they used and validated for PAH or pulmonary arterial hypertension only, or can they be used for patients with non group one or group twos, group threes, et cetera, group fours?
So Reveal 2.0 and Reveal Lite 2, as well as the three strata and the four strata system, which includes the Swedish registry algorithm also, have all been heavily validated in pulmonary arterial hypertension or group 1 pulmonary hypertension. However, there have been recent studies like the very large Go Deep registry, which is both a European and US initiative that has, geez, close to 40,000 patients in it right now from all five WHO groups. You can see that these risk algorithms are also useful in those disease states. And so, yes, they have been validated in some of these other disease states, and particularly useful in group 4 and 2 and 3. But their level of discrimination is much, much less. So remember, the important thing about these risk algorithms is you want as a discriminatory score as possible. And we usually judge this level of discrimination using tools, statistical tools like the C-index. So to use a clinical algorithm in the clinic, you have to have a C-index greater than 0.7. That gives you enough confidence in the score that it can be applied to a general population of patients with the disease that you've tested the algorithm in. And so in PAH, all these scoring systems have C indices greater than 0.7 consistently, with Reveal having the highest of those. However, in these other disease states, even though they have been validated and they are statistically significant in predicting outcome, their C indices only fall in the 0.6 range. And that makes them only a kind of a fair scoring system. And so I think you could use them, but boy, you got to use a lot of adjunctive other methods to predict risk in those disease states. Importantly, comorbidity. So you can't really hang your hat on them in those other disease states. They may guide you a little bit, but certainly at this point, you can't hang your hat on the risk predictions that they give you because they're only fair.
I appreciate that kind of overview and further explanation because I think that can be a area of complexity and dare I say confusion clinically, not rarely. So thank you so much for outlining that.
The nice thing, though, Kathryn, is to recognize that while, we may have hit the head on the nail with these algorithms because what are all these WHO groups have in common? The patients all die from right heart failure. And that's what these calculators really represent, particularly the Reveal calculators. They represent the burden of the disease on the right ventricle. And so this is shared throughout all the five groups. So that's why I think you can get a good baseline prediction out of them, but you're going to have to add other stuff unique to each one of these individual disease states in order for it to be a really good prediction system that you would be comfortable using on a daily basis in the clinic.
Absolutely. I think given what we've talked about so far, maybe we'll kind of try to apply these principles to a few cases if that's okay.
Yeah, that sounds
Uh,
fun.
so we'll start with our first case to talk about how risk stratification would help dictate how you treat this theoretical patient. So first, we'll start with a 28-year-old woman with progressive dyspnea over 6 months and now occurring with minimal activity. She has associated lower extremity edema, as well as an aunt who died young from heart problems in her 30s. Otherwise, her pH workup is unrevealing. She's mildly hypoxemic on room air, tachycardic with a heart rate of 100 and a systolic blood pressure of 90. She has JVP to her jaw. Her NT-proBNP is elevated at 4,850 and her eGFR is decreased. Echocardiogram shows a right ventricular systolic pressure of 95 millimeters of mercury with a dilated and hypokinetic right ventricle, a TAPSE of 12, an enlarged right atrium, and moderate pericardial effusion. Her diffusion capacity on pulmonary function testing is 38%. Her 6-minute walk distance is 180 meters. So what would be your next diagnostic step first for this patient?
So just going through this patient scenario right off the top of my head, this patient is going to be a high-risk patient. Even without the right heart catheterization, which I believe should be the next step, this is a newly diagnosed patient. You really want to define these hemodynamics to make sure that you are not going to underestimate risk. Her reveal score, just off the top of my head, is 13, which really puts her at a very high risk of dying from this disease. You can tell that she's already in right heart failure. This is a person who is dangerously close to the cliff and probably has fallen off the cliff, and someone you're going to want to be very aggressive with. In addition, she's young and she has an aunt with this disease. So this sounds like it could be heritable pulmonary arterial hypertension, in which case you're going to want to do genetic testing, because remember, heritable pulmonary hypertension gives you a higher degree of risk than if you have just idiopathic pulmonary arterial hypertension. So although I know this lady is high risk, I want to make sure I know where her hemodynamics are. And obviously for her future and for her family, we need to know her genetic status. So a right heart catheterization and genetic testing, I think, would be important early next steps to this.
Thank you. And I think one thing I'll just underscore that you already mentioned is that the right heart catheterization is certainly a key aspect of risk stratification for this patient, but will not be sufficient on its own to fully risk stratify. So just again, emphasizing that the clinical status evaluation of objective and subjective metrics of RV function is just as important. So this patient, as you recommended, underwent a right heart catheterization. And just reading for our listeners, her mean pulmonary pressure was 58, her wedge pressure was 10, her cardiac index was reduced at 1.6, her right atrial pressure was 18, and her pulmonary vascular resistance was 12. So you already kind of mentioned that you assess this patient as high risk, which I don't think you would disagree with at this point based on those hemodynamics. So
But the
knowing
other
that,
important
oh,
thing
go
that
ahead.
these hemodynamics give you, Kathryn, it also tells you she is also a Sky Stage C shock patient. So this patient, although she may be ambulatory, she's in early cardiogenic shock. She's got a blood pressure of 90. She's got a cardiac index below 2. She's got a really high right atrial pressure. So this lady's reveal score is like 15 or 16 at this point, which gives her a 60% chance of dying at 1 year. And that's the kind of the interesting thing about using these very granular risk scores. Based on that score, I can tell you exactly what her risk of mortality is based on that individual score. And for someone like this, it's important to know that score, because you're going to use the most aggressive therapy possible to try to drive this lady back for firm footing on that mountain that she's falling off.
Definitely, this is someone we're very, very concerned about clinically. If you were treating this patient, what would you kind of do next in terms of initiation of pulmonary vasodilator therapy, type of therapy, and also would you put thought into potentially hospitalizing her, and or how would you decide that one way or the other?
So from this, for me in my practice, this patient would be hospitalized right from the cath lab to our critical care unit. I would probably keep the swan in her at this point, and I would immediately start her on inhaled nitric oxide, probably some dobutamine to support the right ventricle, and then quickly initiate triple combination therapy for her, including an ERA, a PDE5, and intravenous prostacyclin that I would titrate in the hospital to really achieve two early hemodynamic goals: to get that cardiac index up to 2, and to get that right ventricle decompressed to a right atrial pressure less than 12, because that's where we know the step off in the right ventricle is. It doesn't really have a Starling curve per se. The right ventricle kind of has a cliff effect, and that turns right around a right atrial pressure of 12 to 14. And so that would be my, initial treatment for her. In the cath lab, I probably would have given her INO just to see if she's a responder. Then that would not affect the treatment I would put her on, but at least give me a little prognostic information in the back of my mind, how quickly she might respond to onboarding initial triple therapy for her, in addition to the other things to stabilize her.
Thank you. I think a lot of us would definitely approach it very, very similarly. Question that sometimes comes up clinically, so I'll just kind of ask it. If there was an option for some, there is an option sometimes for patients, even high-risk patients, to start with upfront dual oral therapy, for example. What specifically would be different, say, compared with this patient, that you would perhaps feel like that would be a reasonable approach kind of upfront? So, how would you make that decision?
So I think patients who are in shock need to be hospitalized. So people who are
Definitely.
heavily congested and have a cardiac index less than 2, these are the patients that I want to hospitalize and stabilize and make sure they walk out that door walking and not in a wheelchair. And that's going to require upfront invasive hemodynamic therapy for at least, 4 to 7 days to make sure that they're back on their feet. The fact that this lady's right ventricle, not only by hemodynamics, but by also imaging, is markedly impaired, suggests that this is a high acuity patient and this is not someone you want to mess around with. And I don't think I would start this lady only on 2 drugs, but always with a parenteral prostacyclin.
So perhaps I just want to make sure I'm understanding you correctly for the listeners. So the shock, the cardiac index, the very elevated right atrial pressure, um, all of those things point more towards needing immediate IV prostacyclin. If
Exactly.
those were not present, perhaps she would be more of a candidate for a more dual outpatient oral therapy regimen, at least up front.
So,
Is that accurate?
well, if your hemodynamics weren't as impaired as we thought they would be, even without the hemodynamics, she's still very high risk just from her clinical parameters. And so I still would feel very uncomfortable putting this lady, even if her hemodynamics were a little bit better, just on 2 drugs. And that's the important thing about risk stratification, Kathryn, that you use these scoring systems to kind of give you a base, and then you look at all your other information and you add it to that. So, if we were just using perhaps Reveal Light or the 3 strata system, maybe this person would be a high intermediate risk. But then when you look at the imaging of the right ventricle and see how impaired it is, I would always bump that up a notch in terms of my risk. And that's kind of how I use my tools. So I get my baseline risk using these algorithms and I supplement it then with additional data. And it's always important not to undertreat or not to underestimate risk, because that's when you really hang a patient's life in the wind. If you overtreat, make it a few more side effects, but you're not going to lose important uh, 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 pieces to their life expectancy or their ability to preserve them from having a morbid event like another hospitalization in the future. So I always try, if I need to upgrade their risk a little bit to prevent this underestimation of risk and that promotes less aggressive therapy.
I think that's such an important pearl. So always lean towards overestimating their risk or over treating, as you say, versus under treating. I think that's essential. So thank you so much for highlighting that.
And remember, if you stabilize this person very rapidly, there are things that you can do to simplify their drug regimen. But in this scenario, you want to stabilize first. That's the most important thing.
Absolutely. So I think we'll move on to our next case, a slightly different scenario. So I'll outline that for you. And I think a lot of the approach will be similar in terms of how you think through it and would recommend that we approach it. So now we have a 44-year-old man with progressive dyspnea over the past year or so. He is tired and occasionally lightheaded, but has had no syncope. He's saturating in the mid 90s on room air and has just trace lower extremity edema. He's short of breath walking around the grocery store. His NT-proBNP is 850. His echo shows a right ventricular systolic pressure of 68 millimeters of mercury, TAPSE 18, moderate tricuspid regurgitation, mild right atrial enlargement, normal left ventricular size and function. His 6-minute walk distance is 380 meters. We proceed with a right heart catheterization, which shows mean pulmonary arterial pressure of 48, wedge 9, cardiac index 2.3, right atrial pressure of 8, and pulmonary vascular resistance of 8.2. So how would you stratify this particular patient?
Well, looking at these parameters, and then substituting some of these, we don't have all the data to make a really good reveal or four strata score. Although we can probably do the four strata because we have the NT-proBNP, we have the walk distance, and this person's close to a functional class 3. So, using that, this patient's clear intermediate risk, and even given some points for reveal, that I think his score would still put him in the intermediate risk level, probably a score 7 to 8, so right approaching the intermediate risk range. The walk distance of 380 is not too bad. And if you actually use reveal, it gives you actually a minus point. So I think he's in the low intermediate risk range based on this description.
So how, with that, would you decide on how to treat him in particular, or the situation, similar patient?
So for this person, the first very important thing is to make sure that we are absolutely sure that he has group 1 disease. So I'd make sure I'd look through all the other testing, make sure his PFTs looked okay, his CT didn't show any underlying lung disease. But most importantly, he's a 44-year-old male. I want to make sure that he doesn't have heart failure, preserved ejection fraction. So if he had other risks for heart failure preserved ejection fraction using the heart failure 2 PEF score, I would perhaps have added a fluid challenge to that initial right heart catheterization, and also really characterize the size of his left atrium, making sure that his left atrial volume index was low, to make sure that it's truly group 1 and not another group. And once I've convinced myself that this person is truly group 1, given the fact that he's intermediate risk, I would probably start this patient on dual upfront combination therapy with an ERA and a PDE5.
Thank you. I think that's a very common combo clinically, as you know. For this patient, and I know it'll probably be different than compared with the first patient, of course, but for this patient, approximately how long after starting treatment do you think about reassessing the patient in clinic?
Well, if you look at all the clinical trials and really scrutinize where parameters start changing after initiation of therapy, it's somewhere between the 8 to 12 week range. And so for me, for an intermediate risk patient, I always try to see them within 3 months of starting a new therapy and redo their risk stratification at that point using Reveal Light 2 in my practice, and others may even use the four strata system in other practices to make sure that we're getting this guy moving in the right direction. Because remember, our goal of risk stratification is to try to make patients low risk. Now, that's something we maybe actually want to talk a little bit more about, because what the current consensus is of low risk is really just based on mortality. So we want these patients to have greater than 95% chance of living over the next year. But we don't account in that current definition of low risk morbid events. And so to me, a really low risk patient is someone who has a very low risk not only of dying, but also of having a morbid event like a hospitalization. And so in my own practice, my treatment goals are first to make them low risk, so a reveal score less than or equal to 6. But truly, I work for a reveal score of 5 or less, because those patients I know really have a low risk not only of dying, but also of having morbid events. And those patients on the fringe of low risk, like a reveal score of 5 or 6, where they still have a low risk of dying, but still have a higher risk of having morbid events, I might be more aggressive in those people, even at that level of low risk.
I think that those nuances and insights are so valuable because I think that clinically sometimes we're happy, so to speak, that we get their reveal score in the low range, for example. But I think highlighting that we could even potentially do a little bit better is always, of course, preferable, and I'm sure our patients would totally support that as well, of course.
And that's when that tool belt of yours is going to come in
Yes.
handy, right? Because if you got someone right on the upper end of low risk, you're going to look at their echo, and if that RV is dysfunctional, they may need an extra push to get them really to a low risk category. So this is again where the tool belt concept really helps in kind of refining those decisions, particularly in those border zones between low and intermediate and high. Again, never to underestimate risk.
Absolutely. I think that's a key takeaway from our session today, and I think that's a really important one for everybody listening. One brief follow-up question. When a patient is diagnosed at low risk, which I feel like clinically, at least in my practice, is not that common, but it does happen sometimes. How do you approach treatment decisions and also treatment goals? I think you mentioned, if they start at low risk, potentially targeting even a lower reveal score, but any other kind of pearls or recommendations for that particular patient population?
Yeah, so again, when people are on those fringe points, for example, for me, a reveal score of 6 is right on the fringe point between low and intermediate risk. Again, that's where I pull out the rest of my tool belt. I'll look at their echocardiogram in high detail, and if I still see right ventricular dysfunction, that's something I'm going to be tempted to add a third agent on. And that third agent could be a really great opportunity to discuss other things, particularly with the advent of sotatercept that has come onto the market, and these newer remodeling agents. And that's an opportunity, I think, where I might actually use a drug like sotatercept to really bring them down into the reveal range of, less than or equal to 5. Because then I know I'm cutting off their likelihood of having hospitalizations too. So that's again where using all the tools in your tool belt, not to underestimate risks, is going to be very key.
Well, this has been so informative, Dr. Benza, and we're just so grateful for your time and expertise. I'll leave you kind of now I want to give you another opportunity. Anything that you wanted to touch on about risk stratification that we haven't touched on today, or anything you wish that more clinicians were familiar with or understood in a different way?
Well, I think the important message, Kathryn, is that you should risk stratify and you should risk stratify frequently and use the testing that you're most comfortable with and that really works with your clinical workflow. In my own, I choose to use the more discriminatory tools like Reveal and Reveal Lite. I think they're as easy to use as the others and give you that higher level of discrimination. I think using all the tools in your tool belt, risk scores are your biggest tool, like we mentioned at the beginning, but use every piece of information that you get to make sure you don't underestimate risk in patients. And recognize there are a lot of holes in our current risk assessment algorithms. Remember, our C indices, as we talked about, are in the good range. So we can use these, but they're certainly not in the excellent range. And that's really where we want to push discrimination to the next components. And whether this may be using additional variables or different statistical tools, perhaps Bayesian analysis, which allows us to look at the interaction between variables themselves in addition to variables in the outcome, but also additional things that are emerging, like important biomarkers, whether they're genomic or proteomic biomarkers or other advanced imaging, all should be used in the future, I think, to really encapsulate the best risk possible assessment for these patients, because this is a rapidly progressive disease and you don't want to miss the opportunity to be aggressive when you need to. So I think are the important end things that I'd like to leave you with for this podcast.
Well, thank you so much, Dr. Benza, once again for your time and expertise. This was an excellent session, and I know I learned a lot, and I'm sure our listeners did as well. So thank you again. And to all our listeners, thank you for joining us, and stay tuned for our next episode of Practical PH.
Thanks so much.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.